Normally, I do these procedures with the patient under local anesthesia only. This patient is having some adjunctive lower lid procedure done and is under general sedation, general anesthesia. During the marking, we're going to mark the brow, the cheek, the jowl, and the neck, each zone. So in the marking process, you need to determine the shape of the brow that the patient wants to achieve. If it's just a tail of the brow elevation, you'll be deploying in the lateral half or lateral third of the brow. If it's a complete medial, central, and lateral brow, then you'll be deploying more of your contour articulus threads. The first thing I do in brow marking is I feel for a notch. 80% of patients have a supraorbital notch, usually in the mid-pupillary line, where the supraorbital neurovascular bundle exits. The supratrochlear usually is in the medial portion of the head of the brow. You want to avoid that because one of the dysesthesias that commonly occurs is the lateral sensory branch of the supraorbital nerve. You don't want to skewer that. With the new articulus thread, we have one common deployment at anchor point, and I usually pick that right in the hairline, back a few millimeters, just in case there's any visible mark left by the deployment and the anchor point. And I want to pick up the tail of the brow. So one of the arms of the articulus contour thread is going to go in that direction. I'm going to come just medial to the supraorbital notch. The other thing you need to be aware of when doing the brow is the temporal hollow. The temporal hollow is one of the danger zones where the terminal branch of the frontotemporal nerve runs. So you can feel the zygomatic arch here, the zygomatic arch. And this is that temporal hollow, which is bordered by this frontotemporal line. And there's the temporal hollow. We want to stay out of that area. And so we're very safe, both for our dissection with our sharp point dissector and the passage of the contour articulus thread. I exit on the other side, the superior side of the brow, just above the hairline. X marks the spot. The reason I do that is there is a nice fibrofatty roll in the brow that mitigates inferior descent of the contour thread, and when you go below there you'll get some threads that poke out through the thin upper lid skin, so I stay above that fibrofatty roll. This patient wants a generalized elevation of the brow, so we'll pick a second point in the hairline to deploy our contour thread. Now if you have a situation where the hairline is very, very high, you may need to pick a transverse rhytid to go through. In this particular scenario, we will be able to go around the corner. So we're going to deploy from the hairline, come now medial to the supraorbital neurovascular bundle, and exit medial and medial just above the hairline, but respecting the supratrochlear neurovascular bundle. And there's our second contour articulus thread. So we have two loops, two loop lifts, one medial and one lateral to elevate the brow. And we would do the same on the contralateral side to match the lift on the other side as well. There's our neurovascular bundle. There's our exit points, deployment port, and anchor port, and trajectory. We're now going to mark out the face, jowl, and neck. So first of all, marking out the face. Our goal in the face is to elevate the upper face, this cheek fat pad. Get that elevated as superiorly as possible to meet this hollow infraorbital orbital malar groove that the patient has. Lift the cheek fat pad up. Lift as much of the jowl north as we can, and what doesn't move north, we want to move posteriorly to define the jawline. The first things I mark out are the anatomic boundaries of importance. Mark out the nasolabial fold. Mark out the labiomental fold. She has a little bit of pre-jowling. There's her orbital rim. And we know that the zygomatic arch is right here. We know that the frontal branch runs in a course something like this, but is very, very deep, right down on periosteum. So as long as we're subcutaneous in the temporal tuft, we'll be very safe. Once we have those marked out, I generally try to deploy my 4 facial contour articulus threads above the jowl and above. So I divide the face into commissure and alar base. I always exit about half an inch lateral to the nasolabial and labiomental fold. As you get medial, the 2 or 3 facial muscles subserved on the superficial surface, the levator labii superioris or the levator aliquae nasi muscle and depressor labii inferioris or the mentalis become vulnerable, as those fine terminal motor branches are vulnerable to the deployment needle of the contour articulus thread. So stay lateral to the nasolabial labiomental line, you should be safe. I want to get the upper part of the malar fat pad elevated right here. This part of the malar fat pad elevated. So I exit half an inch lateral to the nasolabial line at about the alar base. Come down to just above the commissure. There's the lower part of the malar fat pad. I'm going to exit just above the commissure. And about half an inch to an inch lateral to the nasolabial line. Below the commissure, I want to pull directly on the labiomental line, just below the commissure, and directly on the jowl. So those are the 4 common exit ports that I then have. We now need to deploy an anchor. We want to pick the temporal tuft as our zone. So we have a deployment port and an anchor port. A deployment port and an anchor port. And these 2 contour articulus threads will come out onto the face as such, and same from this port. Now, to create a strong jawline, we want to pull as much as we can posteriorly the face up into the hair and posteriorly along the jawline. In order to deploy the full strength of the articulus thread, I try to take most of the excess face up into the scalp first. And in order to do that, I do a temporal scalp thread that is very, very safe using the articulus contour structure. So we get the hair out of the way, and remember, my goal is to pull as much of the face into the hair as possible, so I minimize the bunching of the tissue, the Venetian blinding of the tissue in the hairline. So I go up into the scalp and I feel for where the parietal bone is starting to curve around, or the temporal bone is curving around to become the parietal bone, and that's where I'll enter. So I'm going to have 2 entrance points right here, about 2 inches apart, and exit points 2 inches apart, and I'm going to use a common entrance point right here. So this point is going to be lifting the face. If we back out a bit, you can see that at that point I get a very nice pull on the face. You can see the effect on the neck as well. If I can get a very, very strong vertical vector there during the CT1 procedure, I will lift a lot of the excess right into the scalp. So I'm going to be deploying through this common port right here a contour articulus thread that will come north into the scalp. So we'll turn that loop upside down, what I call a U-loop lift. We're going to use this common point right here to act as an N, or right side up, N-shaped loop lift. And we're going to use this point for a U-loop lift. So we're going to deploy our articulus thread superiorly here and bring one arm north to exit in our pre-marked spot in the temporal parietal area, and the other arm coming north and exiting about 2 inches away. Then we create a nice U in the scalp, and that U will be used to harvest and lift that face under tremendous amount of tension. Around that terminal anchor point, we will loop the inferior articulus thread that is going out into the face in an N-shaped or right side up loop lift. And we'll see that nice technique. The last part of the face is to define the jawline. We want to define a nice mandibular border. We've lifted as much of that extra 2 inches up into the temporal hair with the U-shaped loop lift. We come out onto the face with 2 N-shaped loop lifts, giving as much of the mid-face lift as we can. We're now going to come out from under the ear lobule. There's an infralobular deployment port, an anchor port. Make sure it's hidden right in the infralobular space there. By staying anterior just under that lobule, you will avoid, in a great number of instances, the anterior branch of the greater auricular nerve. if you come down 7 inches from the tragus, there's Erb's point. That's where the great auricular nerve comes out from under sternocleidomastoid. There's a posterior branch that comes posterior across sternocleidomastoid to the retroauricular area. There's an anterior branch coming to the concha. And if you stay just below the auricle, or the lobule, sorry, you will, in a great number of instances, avoid dysesthesia of the earlobe. Our goal is to have one pass above the mandible and one about 1 finger breadth below the mandible. Where do I exit? Well, I mark out the sternocleidomastoid. There is the anterior border sternocleidomastoid. I feel for the tracheal groove. There's the tracheal groove. And it's in this zone right here I can often secure some additional platysmal fixation. So I come out just below the border of the mandible, 1 breath below, 1 finger breadth below, and that's where we exit. So here is our deployment trajectory. Deployment trajectory, 1 above and 1 below the mandible, to split and really define the jawline. Now, there's always much concern about the marginomandibular branch of the facial nerve. Anywhere along this path, above or below, you can injure the marginomandibular branch. 80% of the time is above the mandible, above the facial artery, right there, 20% below. That's only if you're subplatysmal. If you stay in the subcutaneous space as you're supposed to, the marginomandibular branch is never in danger. Finally, we want to get some tightening on the neck. Tightening on the neck. So I feel for the cervical mental angle here, and that's the level we want to be. We're going to come straight back a little bit superiorly to the anterior cervical angle, about 2 centimeters below for our second one, right up to that posterior cervical hairline. And that will be our common deployment and anchor point. And we want to exit in that lateral tracheal groove, again anteriorly, for all our cervical articulus contour threads. So that'll allow us a good contouring of the neck, definition of the mandible, elevation of the face, both from direct N loop lifts and a U loop lift into the scalp, and elevation of the brow. Now that we have the patient marked, we're going to do a simple prep. I use a chlorhexidine type solution, non-betadine, as I don't like to stain the tissues. And once the patient is marked, I just get their hair nice and wet. We already have some cream rinse in the hair. And this is a sterile technique when it comes to managing the scalp, a sterile clean technique. We use a lot of chlorhexidine type prep on the face. And we'll dab it off, and we use a non-water soluble marker to ensure that we don't lose our marks. Be careful of the eye, of course. And once we have that prepped and draped, we can dab that off, and we will be ready to go. Once you've prepped and draped the patient adequately, and we just use a simple square drape, blue or disposable towel under the head, square drape in triangular fashion across the neck, and keep a sterile field. Very important to have sterile drapes in a sterile field, because the articular suture is 55 centimeters long. It's very long, and you do not want to contaminate the ends before inserting them into the subcutaneous space. So now we're ready for local anesthesia.